Welcome back to the deep dive. Today we are shifting gears. We are turning up the pressure. We aren't just exploring a topic. We are simulating a high-stakes environment. I want you to imagine a specific scenario. I am a postgraduate student. I've got dark circles under my eyes. I'm running on caffeine, and I am standing outside the exam hall at Gujarat University, preparing for my MD anesthesiology finals. And you are my senior MD anesthesia faculty. You are the one holding the keys to the kingdom.
I know that look, I have read everything, but I remember nothing. Look, it's a rite of passage. But don't worry, my job today isn't just to grill you, it's to guide you through the minefield. We are going to take a topic that is absolute bread and butter for the exams and dissect it until there is nowhere left for the examiner to hide.
The topic on the table is jaundice and viral hepatitis. And it is massive. It shows up as a long question in theory papers, usually a solid 20 marker, and it's a favorite for the practical Viva. I mean, it tests physiology, pathology, pharmacology, and critical care all at once.
It is the ultimate intersection. If you are sitting for your MD, you cannot just say the patient is yellow, that is, undergraduate level. You need to understand the biochemical pathways, the specific enzyme defects, the altered pharmacokinetics, and the critical care management of liver failure. We are drawing from Miller, Stolting, Harrison's, and of course, Cisatracurium biochemistry to build a really comprehensive answer.
Our mission, then, is to synthesize all of this into a coherent narrative. By the end of this hour, I want to be able to structure that 20-mark answer and survive the Viva without falling into the common traps. So let's start with Part A, Introduction and Basic Concepts. How do I frame this for the examiner right out of the gate?
You start with precision. In an exam, definitions matter. Jaundice, or icterus, is the yellow pigmentation of the sclera, skin, and deep tissues. But you need to quantify it. It is caused by hyperbilirubinemia. Clinical jaundice usually becomes visible when plasma bilirubin exceeds 30 to 40 micromoles per liter. That translates to roughly 2.0 to 2.5 milligrams per deciliter.
And just to benchmark that, normal levels are usually under 1.2 milligl, correct?
Correct. And here's a practical Viva tip. If they ask you where to look for jaundice, do not just say the eyes. You need to be specific. It is best seen in natural light at the sclera because the elastin there has a high affinity for bilirubin, the nail beds, the undersurface of the tongue, and the soft palate.
Okay, that's a great clinical pearl. But why is this topic so high yield for perioperative anesthesia? I mean, apart from the fact that the patient looks sick, why do we, as anesthetists, care so much?
Because the liver is the metabolic engine of the body. Jaundice is just the flag on top of the building saying engine trouble. If the liver is down, drug metabolism is altered. Coagulopathy is likely. Hemodynamic stability is compromised. Perioperative morbidity and mortality are significantly increased in these patients due to bleeding, infection, and two very scary complications: fulminant hepatic failure and hepatorenal syndrome.
So we are dealing with a potential multi-system failure risk from the get-go.
Exactly. You will see this in exams as describe bilirubin metabolism and the anesthetic management of obstructive jaundice, or short notes on hepatorenal syndrome, or child-Pew classification. You need to be ready for all of it.
Let's get into the weeds then. Bilirubin metabolism. This is the foundation. If I can't draw this pathway, I probably fail the question.
You absolutely have to know this cold. Let's visualize it. Imagine a red blood cell. It has lived a good life, about 120 days. It is now senescent, fragile. It gets trapped in the spleen, specifically in the reticuloendothelial system. The macrophage there, it grabs it and breaks it down.
It's a demolition job.
It is. The hemoglobin is released. It splits into globin, which is just protein. It gets recycled as amino acids, and heme. Now, this is where the biochemistry gets really interesting. An enzyme called hemoxygenase cracks open the heme ring. This releases iron, which we keep, and here is a nugget for the Viva. It releases carbon monoxide.
Wait, we actually produce carbon monoxide in our own bodies.
We do. It's one of the only endogenous sources of CO. It's a tiny amount, but it happens. The remaining straight chain is a substance called biliverdin. It's green. You know when you get a bad bruise and it turns that greenish color after a few days?
Yeah.
That's biliverdin. Then another enzyme, biliverdin reductase, reduces it and turns it into bilirubin. This is the orange-yellow pigment we're talking about.
And this initial form, this is the unconjugated bilirubin, the indirect one.
Correct. And this is a really important distinction. Unconjugated bilirubin acts very differently from the conjugated form. It's lipophilic. It is not water-soluble. It is effectively a grease ball. It cannot just float around in the plasma, which is, water-based. It needs a transport truck.
That truck is albumin.
Exactly. It binds tightly to albumin. This is absolutely crucial because free unconjugated bilirubin is toxic. It is a neurotoxin. In babies, if it isn't bound, it crosses the blood-brain barrier and causes kernicterus. In adults, albumin keeps it safe and transports it to the liver.
This has anesthetic relevance too, right? Because other drugs can compete for that spot on the truck.
A huge point, yes. Drugs like sulfonamides, salicylates, or even free fatty acids can displace bilirubin from albumin. Or, more commonly, if you have a patient with hypoalbuminemia, which is very common in chronic liver disease, you have fewer trucks. This increases the free fraction of bilirubin and potentially the toxicity.
So the albumin truck arrives at the liver. What happens at the hepatocyte?
Okay, so the truck parks at the sinusoidal membrane. The bilirubin dissociates, gets off the truck, and enters the liver cell via carrier-mediated transport. Once inside, it binds to intracellular proteins called ligandin. You can think of them as the warehouse managers that keep the bilirubin from leaking back out. Now comes the most critical step, conjugation.
This happens in the endoplasmic reticulum, and we are adding glucuronic acid.
Yes. The enzyme you must name is UDP glucuronal transferase. It attaches 2 molecules of glucuronic acid to the bilirubin. Why does it do this? Well, glucuronic acid is highly polar. It has a strong negative charge. By attaching it, you turn that greasy, fat-soluble bilirubin into a water-soluble molecule.
So you're basically putting a water-soluble tag on it so it can be excreted in bile.
Precisely. It can now be dissolved in bile. It is then actively pumped into the bile canaliculi. This active transport is the rate-limiting step in the whole process. If the liver cells are sick, this pump fails first. This is a common point of failure.
So it goes down the bile ducts into the small intestine. What happens in the gut?
The gut bacteria get to work on it. They attack it. They remove the glucuronic acid and convert the bilirubin into urobilinogen. Now, urobilinogen has 3 possible fates. This whole process is called the enterohepatic circulation.
Let me see if I can break this down. Fate 1. Most of it stays in the gut, gets oxidized by bacteria to stercobilin, and leaves in the stool. That's what makes poop brown.
Correct. Absolutely correct. Fate 2. Some of it is reabsorbed from the gut back into the portal blood. Because it's in the portal system, it goes straight back to the liver. The liver says, I recognize you, grabs it, and re-excretes it into the bile. It's a recycling loop.
And Fate 3, the last little bit.
A tiny fraction, maybe 5%, bypasses the liver, enters the systemic circulation, goes to the kidneys, and is filtered out and excreted in urine as urobilin. That is what gives urine its normal yellow color.
That pathway is absolutely key because when it breaks down at different points, we get the different types of jaundice. This leads us perfectly into Part B classification. How do we explain the traffic jam analogy to the examiner? I find that helps.
The traffic jam analogy is perfect. Think of the bilirubin pathway as a highway. Jaundice is a traffic jam. So you have 3 scenarios. 1, pre-hepatic. There are just too many cars entering the highway. The toll booth, which is the liver, is working fine, but it's completely overwhelmed. 2, hepatic. The toll booth itself is broken. The cars are arriving at a normal rate, but the processing is slow or completely stopped. And 3, post-hepatic. There is a roadblock after the toll booth. The cars are processed, they're conjugated, but they can't go anywhere. They're stuck.
Okay, let's look at pre-hepatic or hemolytic jaundice first. This is massive RBC breakdown. Things like malaria, sickle cell, a mismatched transfusion.
Right. The liver is working in overdrive. It's conjugating as fast as it possibly can, but it just can't keep up with the sheer volume of bilirubin coming in. So the backlog, the traffic jam, is of unconjugated bilirubin. In the labs, you see elevated indirect bilirubin.
And what happens in the urine? This is a key differentiator.
It is. Remember, unconjugated bilirubin is bound to albumin. It's a large complex. It cannot pass through the glomerulus, the kidney filter. So there is no bilirubin in the urine. We sometimes call this ocholuric jaundice. However, because the liver is cranking out so much conjugated bilirubin into the gut, you get massive amounts of urobilinogen formed, and therefore massive amounts of urobilinogen are reabsorbed and show up in the urine.
So to summarize for an exam answer, high indirect bilirubin. Urine urobilinogen is high, but urine bilirubin is absent, and the stool is dark because of all the excess stercobilin.
Spot on. Now let's jump to the other extreme. Post-hepatic or obstructive jaundice. This is gallstones, cancer in the head of the pancreas, biliary strictures.
The roadblock after the toll booth.
Precisely. The liver is working fine. It conjugates the bilirubin perfectly. It tries to push it into the bile ducts, but it hits a wall. The pressure builds up, the canaliculi rupture, and the bile regurgitates back into the blood. So the backlog this time is conjugated or direct bilirubin.
And conjugated bilirubin is water-soluble, so the kidneys can filter it out.
Exactly. So the urine becomes very dark, You'll hear it described as tea-colored or cola-colored. That is bilirubin in the urine. But now look at the other side of the equation. No bile is getting into the gut, so no stercobilin is being formed. The stool is pale, clay-colored, alcoholic stools. And if no bile gets to the gut, no urobilinogen is formed. So urobilinogen will be absent from the urine.
That's a crucial distinction. Dark urine, pale stool. And clinically, this comes with other symptoms because it's not just bilirubin being blocked. It's the bile salts too, isn't it?
Yes, this is the definition of cholestasis. The retention of bile salts is what causes the intense pruritus, the itching. You will see scratch marks all over the patient's skin. And because bile isn't reaching the gut, you can't absorb fats. You get steatorrhea fatty, floating stools. And critically for us as anesthetists, you don't absorb the fat-soluble vitamins, particularly vitamin K.
Which leads directly to coagulopathy. We will definitely dig into that in the anesthetic section. Okay, finally, the middle ground, hepatic or hepatocellular jaundice.
This is your viral hepatitis, drug-induced liver injury, toxins, cirrhosis. The hepatocytes themselves are sick, they're inflamed, so they can't take up bilirubin efficiently, they can't conjugate it efficiently, and they can't excrete it efficiently. It's a global dysfunction. You get a mixed picture. Both the conjugated and unconjugated bilirubin are elevated. But the defining feature here, the lab test that screams hepatocellular injury, is the massive elevation in transaminases. ALT and AST will be sky high.
Let's talk about those clinical features properly. We mentioned the yellow eyes, the itching, the stool color. But for the exam, we need to list the systemic effects. The so what for the anesthetist. Let's start with the cardiovascular system.
Okay, bile salts are cardiotoxic. They deposit in the tissues. In the heart, specifically in the SA node, they have a negative chronotropic effect. They cause bradycardia. It is a direct effect. It's not vaguely mediated. At the same time, they cause profound peripheral vasodilation and, this is a huge Viva point, a downregulation of alpha adrenergic receptors.
Downregulation of alpha receptors. What does that mean for us in the operating room, practically?
It means the patient's blood vessels are relaxed and floppy. They're often hypotensive at baseline. And if you give a standard vasoconstrictor like phenylephrine, an alpha agonist, it might not work as well as you expect. The receptors are effectively deaf to the drug. You have to be prepared for refractory hypotension and may need to reach for a different agent, like vasopressin.
Wow, okay. Then there's the CNS, hepatic encephalopathy.
The liver's job is to detoxify. When it fails, it doesn't clear toxins from the portal blood, primarily ammonia. Ammonia crosses the blood-brain barrier and gets into the brain cells, specifically the astrocytes. Inside the astrocyte, an enzyme converts ammonia to glutamine. Glutamine is an osmolase. It sucks water into the cell. The astrocyte swells, the brain swells. This leads to confusion, the classic flapping tremor or asterixis, coma, and eventually death from cerebral edema and brainstem herniation.
And the kidneys. We touched on hepatorenal syndrome in the intro. Let's explain that mechanism properly. It's a classic exam question.
It is, and students often get it wrong. The key thing to remember is that the kidneys are structurally normal. You could take them out, transplant them into someone else, and they would work perfectly. The problem is entirely hemodynamic. In severe liver disease, you get massive vasodilation in the splanchnic circulation, the gut. Blood pools there. The body, specifically the baroreceptors, perceive this as low effective circulating volume.
So the body thinks it's bleeding to death, even though the total blood volume might be normal or even high.
Yes, exactly. It thinks it's in shock. So it mounts a defense. It activates the RAAS pathway renin-angiotensin-aldosterone. It releases ADH. It activates the sympathetic nervous system. All of these systems try to conserve salt and water and clamp down blood vessels. The kidneys, in this environment, aggressively constrict their own afferent arterioles to try and maintain systemic pressure. They effectively choke off their own blood supply. That is hepatorenal syndrome. It's a functional renal failure driven by splanchnic vasodilation and intense renal vasoconstriction.
That is a brilliant explanation. Functional vasoconstriction in response to splanchnic vasodilation. Okay, and finally, hematological.
As I said before, it's a disaster zone, a trifecta of problems. One, you have coagulopathy because you're not absorbing vitamin K, so you can't make factors 2, 7, 9, and 10. And in hepatocellular disease, the liver isn't synthesizing the proteins anyway. 2, you have thrombocytopenia because of portal hypertension leading to splenomegaly. The big spleen traps and eats platelets. And 3, you often have anemia from chronic disease or, more acutely, from bleeding from gastroesophageal varices.
Moving to investigations, we have the liver function tests, the LFTs. How do we categorize them for the examiner to sound organized?
You should split them into 3 functional categories. It shows you're thinking clearly. First, markers of hepatocellular injury. These are the enzymes that are inside the liver cell. ALT and AST. If they're high in the blood, it means the cells are bursting open and dying. Second, markers of cholestasis. These are enzymes in the biliary tract, alkaline phosphatase or ALP and GGT. These rise when bile flow is blocked. And third, the most important for us, markers of synthetic function. These measure what the liver makes: serum albumin and the prothrombin time, or INR.
And timing matters a lot here, doesn't it?
Crucially, albumin has a half-life of about 20 days. If a patient's albumin is low, it tells you they have been sick for weeks or months. It's a marker of chronic disease. Prothrombin time, on the other hand, reflects factor 7, which has a very short half-life, just a few hours. So the PT or INR tells you how the liver is functioning right now, today. It is the single best marker for acute liver failure.
Okay, that makes perfect sense. This brings us to part C, the anesthetic implications. This is the exam gold. Let's break down how jaundice and liver disease mess with our pharmacology.
Start with metabolism. The liver is the primary site for phase 1 and phase 2 drug metabolism, driven by the cytochrome P450 system. In liver disease, you have reduced hepatic blood flow and reduced enzyme activity. This means drugs stick around longer. The half-life of opioids, sedatives, benzodiazepines, many muscle relaxants, it's prolonged. The general rule is you need to reduce your doses and increase the interval between doses.
And what about protein binding? We mentioned hypoalbuminemia.
Right, so many of our drugs, like thiopentone, diazepam, and propofol, are highly protein-bound. More than 90% of the drug binds to albumin and is inactive. Only the tiny free fraction has a clinical effect. If albumin is low, the same total dose results in a much higher free fraction. A standard dose can effectively become an overdose. You get deeper anesthesia and more pronounced cardiovascular depression.
What about pseudocholinesterase? That's another one they like to ask about.
Yes, it is synthesized in the liver, so its levels will drop in severe liver disease. This prolongs the action of succinylcholine. Now, usually it's not clinically disastrous. Maybe you have a block that lasts 10 or 15 minutes instead of 5, but you need to warn the examiner you are aware of it and that you'd be prepared for a longer period of paralysis.
Let's put this all together in a preoperative assessment. I have a jaundice patient scheduled for, say, a laparotomy. What is my thought process?
First, determine the urgency and the severity. If it's an elective case and they have signs of acute hepatitis, you cancel it, period. The risk is too high. If it's urgent or semi-elective, you must assess the severity of the underlying liver disease. The classic tool for this is the Child Pugh score. You must memorize the mnemonic. Pour another beer at 11.
Break that down for me.
P, PT, INR for coagulation. A, ascites. B, bilirubin. A, albumin. E, encephalopathy. Each one is scored from 1 to 3 points. A total score gives you a class. Class A is low risk, Class B is moderate, Class C is very high risk, with perioperative mortality potentially exceeding 50% for major surgery. You should also mention the MELD score model for end-stage liver disease. It uses bilirubin, INR, and creatinine. It's less for surgical risk and more for predicting 3-month mortality and allocating organs for transplant, but it shows you're well-read.
Okay, optimization. The patient has a high INR of 2.5. The case is for obstructive jaundice due to a stone. Do we give vitamin K or FFP?
That is the classic Collar's test logic. In obstructive jaundice, the factory, the liver, is working, but the supply of raw material, vitamin K, is cut off. So you give parenteral vitamin K 10 milligram IV daily for about 3 days. The PT should correct significantly. In hepatocellular jaundice, the factory itself is broken. Giving more raw material won't fix it. In that case, you will need to give the finished products, fresh frozen plasma or cryoprecipitate if you need to operate urgently.
And what about hydration?
Absolutely critical. To prevent that hepatorenal shutdown we talked about, you need to keep them wet. Aggressive but careful fluid therapy pre-operatively to maintain a high urine output. The goal is to flush out the bile salts, maintain renal perfusion pressure, and avoid any hints of hypovolemia which could trigger that renal vasoconstriction.
And preventing or managing encephalopathy.
First, look for and treat any precipitating cause, like an infection or GI bleed. Clear the gut of blood, which is a big protein load that bacteria turn into ammonia, and then use lactulose. It works in 2 ways. It's a laxative that clears the gut, and it acidifies the colon, which traps ammonia as ammonium ion, preventing its absorption.
Let's move to intraoperative management. This is our domain. The choice of agents. Let's start with induction.
Propofol is generally the preferred agent. Even though it's metabolized by the liver, it also has significant extrahepatic metabolism in the lungs and kidneys, and a short redistribution half-life. But you have to go slow. The volume of distribution is large because of ascites and edema, but the effect on the cardiovascular system can be profound due to low albumin and vasodilation. Thiopentone is very risky because of the protein binding issue we discussed. A small dose can have a huge effect.
And for maintenance of anesthesia.
The volatile agents isoflurane or desflurane are best. They undergo minimal hepatic metabolism and they preserve hepatic blood flow reasonably well, better than older agents. Sevoflurane is generally considered safe, though there are some theoretical concerns about compound A in very low flow situations, which is probably not clinically relevant. But here is the big one, the absolute contraindication. Strictly avoid halothane.
Halothane hepatitis.
Yes, it's an unpredictable immune-mediated hepatocellular necrosis. In a patient with pre-existing liver disease, using halothane is practically malpractice. It should never be used in adults in this context.
Okay, muscle relaxants. This is the classic exam question. Which one do you choose and why?
The answer the examiner is looking for is Atracurium, or, even better, Cisatracurium.
Explain why. Don't just say Hoffman degradation. I want the full rationale.
Right. Hoffman degradation is organ-independent elimination. The drug breaks down spontaneously in the plasma based on body temperature and pH. It does not need the liver or the kidney to be cleared. This makes its duration of action predictable and normal, even in complete liver or kidney failure. That's why it's the gold standard.
Is there a downside to Atracurium?
Yes. One of its breakdown products is laudanosine. Laudanosine is a CNS stimulant and can, in very high concentrations, lower the seizure threshold. In a standard 1-hour case, it's not an issue, but in an ICU patient on a continuous infusion for days, it can accumulate. Cisatracurium is an isomer of Atracurium that produces much less laudanosine, so it's the cleaner, safer choice, especially for infusions.
What about the common ones, vicuronium or rocuronium?
They are primarily excreted unchanged in the bile. In a patient with obstructive or severe hepatocellular jaundice, their duration of action can be massively and unpredictably prolonged. We're talking hours instead of minutes. If you absolutely must use them, you must use neuromuscular monitoring, a train of 4 monitor, to guide dosing and reversal. But the safer choice is to just use Cisatracurium.
Opioids.
Morphine is a poor choice. Its metabolism is impaired, and it has an active metabolite, morphine 6-glucuronide, which accumulates and can cause prolonged sedation and respiratory depression. Fentanyl is better. It's metabolized by the liver, but has no active metabolites, though its duration will be prolonged. The gold standard, if you have it, is remifentanil. It's metabolized by non-specific plasma esterases, completely independent of the liver. Its duration of action is always short and predictable.
Fluid management intraoperatively. What's the strategy?
It's a very difficult tightrope to walk. You need to maintain adequate intravascular volume to ensure good hepatic and renal perfusion, so you have to be generous with fluids. However, because of low albumin and high portal pressure, they are prone to leaking that fluid into the third space, worsening ascites and causing pulmonary edema. Use balanced salt solutions like plasmolite. Avoid Winger's lactate. A failing liver can't metabolize lactate, leading to iatrogenic lactic acidosis. Using colloids, specifically 5% albumin, is an excellent choice for volume expansion in these patients.
Okay. Post-operative management.
Yeah.
The surgery's over. What are the dangers we're watching for?
The main danger is decompensation. The stress of surgery, hypothermia, blood loss. It can push a stable cirrhotic patient into acute on chronic liver failure. You must watch for 4 key things. 1. Worsening jaundice. This post-operative jaundice can be from pigment load from blood transfusions, drug toxicity, or simply hypotension during the case. 2. Renal failure. Monitor urine output hourly. A drop in urine output is a red flag for impending hepatorenal syndrome. 3. Encephalopathy. Avoid long-acting sedatives. Treat pain effectively but carefully. Epidural analgesia is great if their coagulation was normal enough to place one. And 4. Hypoglycemia. The liver performs gluconeogenesis and stores glycogen. If it fails, blood sugar can crash. You must monitor glucose levels regularly.
Let's shift gears to Part D, viral hepatitis. This is a huge public health issue in a specific exam domain. Give us the 30,000-foot overview.
Okay. Viral hepatitis is simply inflammation and necrosis of hepatocytes caused by a specific virus. For the anesthetist, there are really 3 distinct risks you need to consider. 1. The risk of operating on a patient who has acute viral hepatitis. The patient is at very high risk of dying. 2. The risk to us, the healthcare provider, needle stick injury and transmission. And 3. The risk of managing a patient with the chronic sequelae of viral hepatitis, which is cirrhosis and all its complications.
The different types, A, B, C, D, E.
Yeah.
Give me the exam hook for each one to help me remember.
Okay, simple mnemonics work best here. Hepatitis A and E. The vowels are for the bowels. They are transmitted via the fecal-oral route, usually acute and self-limiting. The key exception. Hepatitis E is extremely dangerous in pregnant women. It can cause fulminant hepatic failure with a very high mortality rate. Hepatitis B, This is a DNA virus. The others are RNA. It's transmitted parenterally or sexually. It has a significant risk of becoming chronic. Hepatitis C, this is often called the silent epidemic, it's primarily parenteral. It has a very high rate of progressing to a chronic carrier state, like 80%, which often leads to cirrhosis and hepatocellular carcinoma decades later. Hepatitis D, this is the defective virus. It's an incomplete virus that needs hepatitis B surface antigen to replicate. You can only get Hep D if you already have or are simultaneously infected with Hep B. It usually leads to a much more severe form of hepatitis.
Let's talk about acute viral hepatitis. The patient comes in feeling unwell, nauseous, then they turn yellow. Their ALT and AST are in the thousands.
The golden rule. You must state this clearly in the exam. Elective surgery is absolutely contraindicated.
Why specifically? What's the mechanism of harm?
Multiple studies going back decades have shown that mortality rates soar up to 10–20% or even higher. The anesthetic itself reduces hepatic blood flow. The stress response of surgery releases catecholamines, which further constrict the hepatic circulation. You can easily tip a fragile, acutely inflamed liver into fulminant hepatic failure. The consensus is you must wait until the LFTs have returned to baseline, and then probably wait another 4 to 6 weeks for the liver to fully recover metabolically.
What if it is a life-threatening emergency? A trauma patient with a ruptured spleen who also happens to have acute Hep B.
Then you have no choice. You have to proceed to save their life. But you do it with extreme caution, and after a very serious conversation with the family about the high risk, you optimize aggressively beforehand. Correct the coagulopathy with FFP and platelets. Use liver-independent drugs wherever possible. Cisatracurium, remifentanil. Maintain their blood pressure meticulously. It's a damage control situation for the liver.
Now, chronic hepatitis. These are the patients who have progressed to cirrhosis. What is their typical hemodynamic profile?
They have what's called a hyperdynamic circulation. You need to know these 3 features. 1, high cardiac output, the heart is pumping hard. 2, low systemic vascular resistance, SVR, because of all the circulating vasodilators like nitric oxide. And 3, low blood pressure. They are warm and dilated, but they have very limited cardiovascular reserve. If you drop their preload, say from surgical bleeding, they crash very, very hard.
And fulminant hepatic failure, FHF. This is the absolute ICU nightmare.
It is. The definition is key. It's the rapid onset of severe liver injury with encephalopathy and coagulopathy in a patient who did not have pre-existing liver disease. The onset is usually within 8 weeks of the initial insult. The thing that kills these patients, more often than not, is cerebral edema. We already discussed the ammonia-glutamine mechanism. So your primary goal in the ICU is to protect the brain from high intracranial pressure. This means 1, airway protection, intubate them early, usually by the time they reach grade 3 or 4 encephalopathy. 2, ventilation, aim for normocapnia. Hyperventilation is a temporary rescue but not a long-term solution. 3, osmotherapy. Use mannitol or hypertonic saline to pull water out of the brain. 4, positioning. Keep the head of the bed up at 30 degrees to promote venous drainage. And avoid anything that raises ICP, like tight ETT tapes around the neck.
Okay, Part E, special considerations. Let's talk about our safety. Needle stick injury. This is a very real risk for us. What is the protocol?
You need to know this for the Viva and for your own life. It's a 3-step process. 1, immediate action. Wash the wound thoroughly with soap and water. Do not scrub it aggressively or squeeze it, as that can increase local trauma and viral uptake. Just let it bleed freely under running water. 2, report. Inform your department's occupational health service immediately. This needs to be documented. And 3, assess and treat. You assess both the source patient and yourself. Test the patient for HBsAg, HCV antibodies, and HIV. Then you assess yourself. For hepatitis B, it depends on your vaccination status. If you are a known responder to the vaccine, your antibody titers are high, you're generally safe. No treatment needed. If you are unvaccinated or you're a known non-responder, you need HBIG hepatitis B immunoglobulin immediately for passive immunity, and you need to start the vaccine series for active immunity.
And what about for hepatitis C?
For Hep C, there is no vaccine and no post-exposure prophylaxis. All you can do is follow up with serial PCR testing. The good news is that if you do seroconvert, we now have excellent direct-acting antiviral treatments that can cure it. But prevention is key. Studies show double gloving can reduce the inoculum volume from a sharp by up to 50%. And always wear eye protection. A blood splash to the conjunctiva is a known route for Hep B transmission.
Let's clarify timing of surgery one last time for the notes. Just the hard and fast rules.
Okay, the rules are 1, acute hepatitis. Defer all elective surgery until LFTs normalize, then wait another 4 to 6 weeks for full metabolic recovery. 2, chronic hepatitis cirrhosis. Assess with child Pew score. Class A and well-optimized Class B can proceed with caution. Class C should avoid elective surgery entirely. 3. Severe obstructive jaundice. You optimize coagulation with vitamin K and hydrate them. If the bilirubin is massively high, say over 15 or 20 mg/dL, you should discuss with the surgeons about pre-operative biliary drainage via ERCP and stenting. Let the liver recover for 4 to 6 weeks, then do the definitive surgery.
Fantastic. Part F, exam integration. Let's look at the Viva traps. I'll throw a common scenario at you, and you tell me the trap and the safe answer. Okay, scenario 1. The patient has obstructive jaundice. The INR is 1.8. The surgeon is pushing for a spinal anesthetic for a hernia repair.
The trap. Performing neuraxial blockade in a patient with coagulopathy. The safe answer. A spinal anesthetic is absolutely contraindicated with an INR of 1.8 due to the unacceptable risk of an epidural hematoma, which could lead to permanent paraplegia. The coagulopathy must be corrected first. If it cannot be corrected, the patient requires general anesthesia.
Perfect. Scenario 2. The cirrhotic patient's BP drops to 70/40 on induction. You give a small bolus of phenylephrine. Nothing happens.
The trap. Forgetting the pathophysiology and underdosing the vasopressors. The safe answer.
Sure.
Patients with liver disease often have downregulated alpha-adrenergic receptors and can be refractory to standard doses of alpha agonists. I would be prepared to use larger doses or switch to an alternative vasopressor like vasopressin, which works on V1 receptors and is often more effective in this setting.
Final one. Scenario 3, a classic. Can we use halothane in a child with jaundice?
The trap. Generalizing the halothane ban without nuance. The safe answer. Halothane hepatitis is an immune-mediated phenomenon and is extremely rare in prepubertal children. However, in modern anesthetic practice, safer alternatives like sevoflurane are universally available. Given the pre-existing liver condition, it would be prudent and standard of care to use an agent with no risk of hepatotoxicity. So, while not an absolute contraindication in a child, it would not be the first choice.
Let's talk about diagrams. For the written paper, what should I draw?
3 things will get you maximum marks. 1. The bilirubin flowchart. A simple diagram showing RBC breakdown, hem biliverdin, unconjugated bilirubin liver conjugation, gut, stercobilin stool, and urobilinogen, urine. Label the key enzymes like hem oxygenase and UDP glucuronal transferase. 2. The classification table. A simple 3-column table comparing pre-hepatic, hepatic, and post-hepatic jaundice across key findings, urine bilirubin, urine urobilinogen, and stool color. And 3. The child Pew table. Just write out the 5 criteria and the scoring system. It shows you note cold.
And finally, let's tie it all together. Structure that perfect 20-mark answer.
Okay, here's the skeleton. Introduction. Start with a crisp definition of jaundice and the normal bilirubin values. State its importance in anesthesia. Physiology. Briefly trace the pathway of bilirubin metabolism. This is where you draw your flowchart. Pathology. Classify jaundice into the 3 types. This is where you put your comparison table. Then, discuss the systemic effects of liver dysfunction, cardiovascular, renal, CNS, hematological, pharmacology. Dedicate a paragraph to the altered drug handling metabolism, protein binding, and specific drug examples. Anesthetic management. This is the biggest section. Structure it logically. Preoperative. Assessment, mentioned child Pew, investigations, and optimization. Vitamin K, hydration, lactulose. Intraoperative. Choice of agents, propofol, Cisatracurium, romifentanil, isoflurane, hemodynamic goals, and monitoring. Postoperative. Key concerns like pain management, monitoring for renal failure, encephalopathy, and hypoglycemia. Conclusion. A single sentence summarizing that managing a jaundice patient requires a deep understanding of pathophysiology to mitigate the significant multisystem risks.
Let's wrap up with a final rapid-fire summary. Give me the high-yield take-home points.
Okay, here we go. 1. Jaundice is a systemic disease, not just the skin color. 2. Protect the kidneys. Aggressive hydration is key to preventing hepatorenal syndrome. 3. Fix the clotting. Give vitamin K for obstructive jaundice, FFP for hepatocellular failure. 4. Pick the right drugs. The mantra is Cisatracurium, remifentanil, and isoflurane, and absolutely no halothane in adults. 5. Remember, the alpha receptors are downregulated. Be prepared for refractory hypotension. 6. Never ever do an elective surgery on a patient with acute viral hepatitis. 7. Know your needle stick safety protocol. Wash, report, and get HBIG if you're a non-responder.